Good morning, everyone. I'm Ava Kadiwada. I'm one of the internal medicine chief residents this academic year, and welcome to Grand Rounds this morning. Today is my pleasure to introduce our speaker, Dr. Maddox. Dr. Maddox is the inaugural executive director of the Healthcare Innovation Lab at BJC Healthcare and Washington University School of Medicine in St. Louis. The lab catalyzes care delivery innovation through research and development. Dr. Maddox is also a practicing cardiologist and a professor of medicine in the Division of Cardiology here at WashU. He's also a health services researcher. His research interests have focused on healthcare delivery innovation, learning healthcare systems, and quality of care in cardiovascular disease. He has authored over 230 peer-reviewed publications, received multiple grants exploring optimal care delivery, and holds national leadership positions in the American College of Cardiology and the American Heart Association. Thank you so much for joining us this morning, Dr. Maddox, for Grand Rounds.
Well, thank you and good morning, everybody. I'd like to speak to you today about digital health and our BJC WashU Healthcare Innovation Lab. These are my disclosures with grant funding, as well as some honoraria and expense reimbursement. I did want to note, as part of my employment, I'm advising Maya Labs, which I'll speak about a little bit later in the presentation. And it's important to know that BJC and WashU have a small equity stake in this company as part of this arrangement, although I myself do not receive any individual compensation. And I'll bring that up at the relevant point in the presentation. So our Healthcare Innovation Lab catalyzes care delivery innovations through research and development. We were formed about 3.5 years ago in June of 2017. And we are a small group of program managers, healthcare administrators, and clinicians that identify innovations in care and evaluate their usefulness for the care that we provide here at BJC and WashU. We look for innovations in all the types of care that we provide, be it medicine, surgery, OB, pediatrics, and so on. To get a clear sense of what we do, I think it's important to first start by defining the term innovation. So innovation is a new idea that, when implemented, creates value. And I think all three concepts embedded in this definition are important. A new idea really just needs to be new to us. It doesn't have to be new to the world, but it may be new to healthcare from another industry, or it just may be new to our particular healthcare that we provide here at WashU and BJC, and that we can learn from other progressive health systems. The second concept, implementation, is essential. I think it's captured best by Thomas Edison, who said, vision without execution is merely hallucination. And that's true for healthcare innovation as well. We must implement for it to be relevant to us. And then finally, of course, the whole point is to provide value. And in healthcare, that's improved health and outcomes for our patients, lower costs for providing that, or ideally a little combination of both. So one of the main forms of healthcare innovation in 2021 is digital health. It's a very promising approach to care delivery innovation here. Digital health, most broadly defined, is the use of digital information and digital communications technologies to collect, share, and manipulate health information in pursuit of optimal health care and outcomes for our patients. Now, in the past 10 years or so, we've seen an enormous increase in the amount of digital health information available to us. And the biggest source of this information, obviously, is the electronic health record, which now characterizes care in well over 90% of hospitals and clinics around the country. There's also been a more recent increase in the number and variety of wearables, activity monitors, and other digital devices that track patients' health outside of the health system. And then finally, there have been significant advancements in how to analyze this massive amount of digital data using techniques such as artificial intelligence and machine learning methods. So while all these developments are exciting, we are only now just beginning how to tap into their potential and see how they can impact our patients' health. So that's what our lab is trying to do. And we are currently focusing on 3 areas where we think digital health holds a lot of promise for us and our patients. Those 3 areas are predictive analytics, digital care, and remote patient monitoring. So predictive analytics involves the use of data, both within and then beyond the traditional healthcare system, to predict the course of a given health condition. For example, predictive models have been designed that integrate a variety of medical history data, patient-reported symptoms and outcomes, and biometric data to predict heart failure decompensation. We know that any successful predictive analytic project requires both high-quality data and then advanced analytic approaches to appropriately interpret it. They also require knowing how predictive information then integrates into the clinical workflow and the clinical care that we provide so that it can translate to better outcomes for our patients. Digital care has become a very common application of digital health, and this uses digital tools to assist with more traditional care delivery. For example, digital tools can help monitor a patient's mental health status. It can help connect patients to transportation needs or other social services, and it can provide efficiencies to clinical supply chains. And then finally, remote patient monitoring is a third aspect of digital health that we'll discuss today. Monitoring programs allow for more continual monitoring of high-risk patients while they're either at home or at work, and wearable sensors to monitor these patients have become much more sophisticated in the past few years. Monitoring programs are often couple these sensors with communication platforms to facilitate care team connection and monitoring. Now, these programs generate an enormous amount of digital data, so there needs to be an effective way to manage it. And we will discuss different approaches to do so, but generally it has been addressed with specific data triage plans and time-limited monitoring periods. So with all these areas of digital health defined and the endless possibilities they provide for care delivery innovation, how do we at the lab select innovations on which to focus? We start by considering the clinical care journeys that our patients take. And this graphic you see here represents the typical journey that most patients take for their care, regardless of whether or not they're managing heart disease, treating cancer, or delivering a baby. As you can see in the upper left hand, a patient searches for the care team best suited for them, contacts them for an appointment, completes pre-service activities like completing medical histories or prepping for a procedure. They arrive either in person or virtually to receive their care. They receive that, and then they are discharged from the clinic or the hospital or even the video visit and need to complete follow-up activities like, say, imaging or prescription fulfillment. And then finally, they need to maintain the care or engage in those activities so that will sustain their optimal health, like taking medications, making changes to their diet, or engaging in an exercise routine. So with this context, we focus our innovation projects on key points of the patient care journey where we hypothesize digital health can provide significant value. And in particular, we have conducted many projects on the care delivery portion of the patient journey, where both predictive analytics and digital care are particularly helpful. And we've also conducted many projects on the maintenance of care portion of the journey. And this is where remote patient monitoring can be particularly valuable, given its ability to monitor the patient outside of the traditional healthcare setting. So I will spend the rest of the talk describing how our innovations in predictive analytics, digital care, and remote patient monitoring support our patients' care journeys. Let's begin with predictive analytics. We will discuss sepsis prediction, clinical decompensation prediction in oncology patients, post-operative complication prediction, palliative care prediction, COVID and influenza mortality prediction, and then finally, clinician burnout prediction. Predicting sepsis was one of the first projects that we tackled. As you may know, Epic, our electronic healthcare record, has a built-in sepsis prediction model. So we first wanted to know, is that model already available to us useful? And the short answer is it wasn't. We looked at its performance for suspected infection, sepsis onset, and death in our particular patients here at BJC and WashU. And we saw that on average, it only had an area under the curve, which is a measure of its discrimination ability, of about 0.6, which is modest to somewhat weak in its ability to do that. In addition, it had a low positive predictive value, which you can see illustrated in the third row of the graphics illustrated here. And the positive predictive values were well below 20%, which meant that we often had false positives and a misallocation of resources. So we needed a better solution. One of the teams that we help support is led by Drew Michelson in pulmonary critical care, and he's been developing a better model that can predict sepsis, in some cases 6 hours before its onset. Its discrimination was significantly higher using machine learning methodology, and its AUC, as you can see here on the graph on the left, is north of 0.9. And he was also able to improve the positive predictive value to around 50%. Which is significantly improved and much better for resource allocation. We also learned that it's important to use this model in areas where the prevalence of sepsis is relatively high so that you can optimize your positive predictive value. And since sepsis is more prevalent in our ICUs than in the ED, the model is particularly helpful when pointed at our unit patients. In contrast, if your goal is not to miss cases and maximize your negative predictive value, then this model is effective in places like the ED or the inpatient wards. Another improvement that they were able to provide is to be able to understand the factors that drove sepsis prediction, and thus reduces the black box phenomenon of machine modeling. Now, the black box phenomenon is the inability to know immediately what inputs are informing the output of a machine learning model. And this makes it harder for clinicians to know what's driving a particular patient's risk, and thus what to do about it to reduce that risk. So Drew and his team employed a technique called the Shapley additive explanations, or SHAP analysis, that helps explain why a model is indicating that a patient's at particularly high risk for sepsis. And you can see here a SHAP graphic that lists in descending order the explanatory values of the machine learning model. In this case, high respiratory rates and low blood pressure values were major predictors, while the labs listed lower in the list were relatively less contributory to explaining the risk. This finding is clinically consistent with what we see on day-to-day care, which is important for clinicians' acceptance of model results. And it also suggests that a significant portion of model performance is due to vital sign monitoring. Thus, it's critical that we make sure that vital sign data are reliable inputs for ongoing monitoring of these patients and modeling of their outcomes. Let's discuss our prediction work for clinical deterioration of oncology patients. As you just heard from our sepsis work, we can build informative predictive models with our machine learning techniques. However, we're not done with that. We then need to know how to integrate the information from the model prediction into our clinical workflow. And one of our teams, led by Pat Lyons in pulmonary and critical care, is working with our inpatient care teams to understand this a bit better. The team has been interviewing inpatient clinicians about how they would like to see predictive model information during their workday. And we found that these teams prefer that prediction models for clinical deterioration are displayed passively in the EHR, but also with the appropriate clinical context. Now they found these ideas out by asking, among other questions, if a computer program identified your patient as high risk for needing more intense care, what would you like to have happen next? And as you can see in the results to the right, the majority did want the alert to be passive and just observable, although a significant number, 48%, didn't mind an interruptive alert or another way of alerting the care team. They also indicated that they wanted other clinical information available to place this alert in clinical context and understand the overall status of the patient. And then finally, they expressed a desire to not only know if a patient was at high risk, but what exactly to do to help minimize that risk. So with that user input, we developed a patient list rank ordered by clinical deterioration risk. And Pat and his team have partnered with the software development shop here in town and co-designed a user interface that you can see displayed here. This user interface rank orders patients by risk and then provides contextual clinical information, which reflects the need that we heard in our initial design interviews. Now, the initial clinician feedback to this prototype has been good, and so our next step will be to further refine it, integrate it into Epic, and then determine where in a clinician's workflow and to what members of the clinical team do these alerts need to appear. We are doing similar clinical integration work with our post-op prediction project. This team is being led by Brad Fritz in anesthesia, and he's interviewed fellow anesthesiologists, CRNAs, and residents about what they wish to see in output from a model predicting, in this case, poor post-operative outcomes. And you can see the clinician preferences for model output in this situation included knowledge about modifiable risk factors, smart workflow integration, and then importantly, simple data displays. So smart workflow integration meant that clinicians would see the model information at the same time that they were reviewing the chart prior to the surgery. And simple data displays meant displays that minimized the time and the cognitive energy that was needed to interpret complex data. They identified several strategies for this, including simplifying the interface display layout, indicating risk level with color, say indicating high risk with red, providing a hovering ability that a clinician could use to hover over that risk score to understand what was causing that risk score to be indicated as high, and then showing risk trends over time for longitudinal context. So with this kind of input, Brad and his team can now design a simple and probably just a paper-based display prototype to put back in front of these clinicians to see if they can represent it in a way that is useful to them. And then once we get that feedback and iterate it to a workable model, we can then put it into an electronic format and work on integrating it into the electronic record. In another post-op complication prediction project, we found that predictive models using intraoperative data had similar accuracy to medical history data. This is a team led by Ryan King, also in anesthesia, and he had developed models to predict poor post-operative outcomes, such as pneumonia, AKI, DVT, PE, and delirium. To develop these models, they used the inputs of intraoperative data, indicated here by the bars in blue, and then preoperative clinical history data, indicated by the bars here in orange. Now, the height of the bars indicates the area under the curve or the discrimination ability of the various models. And as you can see, based on the bars in green, the best performing models use the combination of intraoperative and preoperative data. However, look at the absolute AUC values of the intraoperative data alone in blue. They are all around 0.7 and 0.8, which is an excellent discriminatory ability. And it suggests that even if we only have the intraoperative data alone, we can still get valuable information for our models. And the intraoperative data has the advantage of generally being more complete and of higher quality than some of the clinical history data. And it underscores our need to understand the marginal gains of various data types in our predictive analytics and balance that with the cost of their collection so that we're getting useful information in the most cost-efficient way. Another predictive project that I'm particularly excited about centers around palliative care needs. This team, being led by Nate Moore, primary care physician with the BJC Medical Group, and Pat White in palliative care, sought to identify patients at high risk for 30-day mortality. And then once we identify these patients, we can then ensure that we've elicited their goals of care so that we're delivering the desired intensity of care. And as you can see, the models here for 30-day mortality were highly accurate with an AUC of 0.89. And this allows for intelligent triage of our primary and palliative care teams to the patients who might need their services. The models have gone live in the past month, both at Missouri Baptist Hospital and here at Barnes Jewish Hospital. And among the initial patients identified, their primary care teams were notified about their high mortality risk and prompted to have a goals of care discussion with their patients. Unfortunately, almost all of the teams and patients were able to have these conversations. A good number of patients elected to move to palliative or hospice care, while others did not want that at this time. But the point is that all had clarification of their goals of care and a conscious decision and discussion with their care teams. And it ensured that our treatment plans then could be tailored to be concordant with their wishes. Recently, we've had another team start to look at predictive models to distinguish COVID from influenza, given the fact that we are now moving into that time of year where the two can co-occur. This team, being led by Patrick Sinha in anesthesiology, used historical mortality data for both COVID and the flu and started modeling the clinical predictors. They found that each condition had unique predictors and phenotypes, such as the variables seen listed here in Table B, that in the COVID model, the models were driven by age, troponin, blood pressure, and potassium and creatinine levels. In distinction, the influenza model was being driven by the amount of oxygen requirement, albumin levels, blood pressure, pulse ox values, and an absolute neutrophil count. In addition, as seen in Table C, temperature trajectories were also distinct between the two models and clinical conditions. Now, this suggests that these models may be able to assess various clinical variables in patients with an unexplained viral illness upon presentation and predict whether it is from either COVID or influenza and the subsequent risk of these patients for severe disease and a higher mortality risk. Finally, the last predictive analytic project I wanted to highlight was one that focuses on clinicians instead of patients. This team is being led by Sunny Liu in anesthesia, and she and her team are seeking to predict house staff burnout using EPIC interaction data. And we know, unfortunately, that there is a high prevalence of burnout among medical trainees. And you can see on the top chart that burnout rates among our house staff here at WashU hover around 20% per year, which is consistent with national trends. In the bottom chart, you can see the breakdown differentially by specialty type and year. For example, the medical specialties indicated by the blue bars tend to have their higher rates of burnout in year 1 or the intern year, while surgical specialties in the yellow bars have theirs in year 3. In our current assessment for this project, we did some polling of the house staff, and we actually found that burnout symptoms, at least mild symptoms, were prevalent in a large number of house staff, on the order of 46%. And so now what we're doing, in addition to responding to those signs of burnout through the residency leadership and other programs, we're also looking at EPIC user data to try and understand if we can get early warning signals about impending burnout and then provide early intervention to avoid any worsening of that issue. So we're looking at EPIC characteristics such as the length of time spent in the EHR, the number of off hours spent with EPIC, and the rate of order errors. If any of these or other measures correlate with burnout and even more ideally predict it, then we can target interventional strategies accordingly. So in summary, all of these projects have taught us a lot about the promise of predictive modeling in care delivery innovation. Let's move to digital care. So we'll discuss non-emergent medical transportation, voice assistance for clinical supply management, voice assistance for preoperative stress management, and automated depression detection and management. Our first project is using a digital platform. We have provided free rides to over 5,000 patients from our hospitals, emergency departments, and clinics. Now, as many of you may know, transportation issues affect many of our patients. And they either don't have their own transportation or anybody in their world that can provide transportation to get to clinic visits or get home from ED evaluations or inpatient hospitalizations, which results in long delays for them and starts to clog up our inventory to be able to treat the next set of patients in these healthcare settings. To address this, historically, BJC has provided up to 16,000 rides for these patients annually, typically by giving them cab vouchers. However, as you may know, cab service is notoriously slow and unreliable. So to address this need, we partnered with a company called Kaizen Health that operates a rideshare service. It is similar to Uber, but with drivers and cars that can handle patients with medical needs. And since we started this program, as you can see, in early 2020, it has provided rides to over 5,000 patients, many of whom live in the northern counties of the St. Louis region, which you can see on the heat map on the slide. Now, the rides are showing up very quickly with median arrival time of 9 minutes, and the patients in general have been very pleased with the process and responsiveness. And the cost has been roughly similar to the cabs. So at the same cost, we're getting a better experience and better impact of the program. Now, since most of the rides were to and from homes in North County, it stands to reason that most of the patients that were benefiting from this program were predominantly of color, poor, and urban, and you can see some of the characteristics here. Now, why does this observation matter? Well, we know that folks who need transportation today are often going to need it tomorrow and next week and next month. And so using this information that we're able to collect on their need today, we might be able to, in the future, offer them additional rides for other medical needs, like outpatient clinic visits or dialysis visits. We also know that transportation needs are correlated with other social determinant of health needs, like food insecurity. So we could also offer them rides to places like grocery stores or other social service organizations. So it illustrates how digital tools not only can address an immediate need, but by the data they collect, identify other opportunities to expand this in other helpful applications. Let's go to a different project. This is an example of digital care using voice assistants that can improve efficiency of clinical supply management. A team led by Po Yen Yen at the Institute for Informatics studied the use of voice assistants to improve the efficiency of finding clinical supplies on our inpatient floors here at Barnes-Jewish Hospital. They found that supply rooms, which are located on almost every floor, were configured differently on different floors, which made it harder for nursing staff to efficiently locate their needed supplies like saline bags or IV starter kits. So they wanted to see if voice assistants like the Amazon Alexa could be used to help. To do this, they developed a syntax library and programmed the voice assistants to direct the clinical team to needed supplies. So a syntax library is simply all the different ways that clinicians can ask for clinical supplies. And to collect this list, which you can see at the top of the slide, they interview clinicians about common ways that they would ask Alexa for supplies. They then matched the various phrases to the supply master list and the locations for those supplies in the various rooms. And then finally, taking these inputs, they built a logic and workflow model into the Alexa, as you can see in the flow chart here. And then by piloting it on 2 of our floors of BJH, we're able to demonstrate that clinicians could successfully ask for and get good direction from Alexa. It thus demonstrated that there's a potential role for voice assistants in clinical care, and in this case, supply management. It also uncovered some interesting and somewhat unexpected challenges. For example, in one of our pilot floors, one of the nurses was named Alexa. So it turns out that when somebody called her by her name, the Alexa assistant would wake up and potentially record sensitive information. So we need to start to think about the downstream implications of voice assistants and account for those. A different project used both smartwatches and voice assistants to detect and manage patient stress. This team is led by Thomas Cannonball at the Institute for Informatics, and he and his team wanted to detect stress among preoperative patients using the PPG sensor and accelerometer on a smartwatch. Now, to calibrate the watch to measure stress, they had patients undergo 3 stressful activities and measure the responses detected by the watch. And you can see the stresses indicated graphically at the top part of the slide. Patients would watch a resting video to set a baseline. Then they were required to prepare a speech for 4 minutes and then deliver the speech for 4 minutes. They had a recovery period. Then they went through a second activity of doing math problems out loud in front of a crowd of people. Then they had a recovery period. And then finally, the final stress was putting their arm for a minute or 2 in a bucket of ice cold water. So by undergoing all this, we could then collect the information from the watch and figure out what correlated to both the stress physiologically as well as the patient's perception of stress. And they were able to achieve accuracy rates of the smartwatch picking this up north of 80% of the time. Interestingly, of these 3 stresses, patients almost unanimously found the math test to be the most stressful by far. The next step in this project will be that for stress patients, we could use a voice assistant and a smartwatch to guide them through a relaxation program. To do this, a voice assistant will walk the patient through various relaxation exercises, as you can see scripted here on the left. And then as the patient completes those, the smartwatch is able to measure their impact through watch-detected changes in their respiratory rate. If this intervention is successful, then it would be another application of using digital tools and specifically voice assistants to supplement care. Finally, a different project led by a team with Abby Chang in orthopedics is determining the role of app-based depression and anxiety treatments among chronic pain patients being seen in our ortho clinics. Using the PROMIS patient assessment tools that are completed when patients come to clinic, we are able to know if we are able to have patient-reported depression and anxiety symptoms automatically incorporated into EPIC in a flowchart format. And that by tracking these patients over time and making them visible to the care team, patients and clinicians can determine if these depression or anxiety symptoms warrant further evaluation or treatment. If so, then we have partnered with Wysa, a mental health software company, to determine if their solution can help improve our patients' mental health. This application takes patients through various talk therapy regimens, which have been proven beneficial for these conditions. And the application itself has had some promising improvements in depression symptom reduction, as you can see here, in small preliminary studies. And what we will do is evaluate its impact, of course, on our patients to see if we can get a similar impact. So in total, these various projects demonstrate how digital tools can supplement care delivery. Let's turn to our final category of innovation projects, remote patient monitoring. We will discuss heart failure patient monitoring, ambulatory COVID patient monitoring, post-pancreatectomy recovery monitoring, environmental monitoring for asthma exacerbations, and finally, cognitive monitoring among diabetic children. So with this project, we are monitoring our heart failure patients with continuous biometrics. We have partnered with the health tech company I mentioned at the beginning of our talk called Maya Health to monitor our heart failure patients. They use a variety of sensors, seen here in the upper left, to monitor the health of these patients. One of the sensors they use is called a ballistocardiograph, which is a pressure sensor that fits under a patient's mattress and collects heart rate, respiratory rate, and sleep patterns while a patient is just lying in bed. Now, since this sensor is always on, it means that we are able to get almost continuous and high quality biometric data, at least while the patient is in bed. And you can see that illustrated in the chart entitled Daily Vital Enhancement. And the sleep sensor has almost 100% fidelity in collecting data over the monitoring period. This is in contrast to sensors that require more patient actions to obtain, such as blood pressure and weight. As we all know and personally experience, it's difficult to do that with perfect fidelity over time. And you can see that represented in the bar chart. So it does mean that if we can find ways to do remote monitoring with passive sensing, we have the opportunity to greatly improve the data and thus the management we can provide in response. On the right side of the slide, you can see a clinician interface that displays the remote patient monitoring data with a timeline of clinical events, medication changes, and other key health information. And these timelines allow for good triangulation of biometric data, medication use, and clinical events. What we've provided here is a little vignette that sort of takes you through the experience of one of our patients who was started on Entresto but was struggling with hypotension. And the alerts from the program were able to have the care team make some medication adjustments to balance the benefit and risk of the medication. They also, due to some severe aortic stenosis, underwent a TAVR procedure, and the medications which were held appropriately for the procedure were able to be reintroduced in a timely fashion, due in part to the ability to monitor the patient at home. We've launched a 100-patient pilot study to study the impact of this program on improving heart failure patients' use of guideline-directed medical therapy and reducing their need for acute emergency department or inpatient care. And the pilot's being led by a number of our heart failure clinicians in the Division of Cardiology, including Greg Ewald, Justin Bader, Justin Hardepy, Ed Geltman, and Amanda Verma. Another project is focused on remote monitoring of COVID patients. Using Epic Care Companion, we have monitored over 10,000 COVID patients in their homes. Starting in April, at the beginning of the pandemic, our IT, virtual care, and BJC and WashU primary care clinicians designed this app-based symptom questionnaire that our patients filled out daily. They would receive a push through the MyChart app and then be asked to report on how they're feeling. They had also received a thermometer and a pulse oximeter, and they provided those values daily in addition to their symptoms. Now, for those patients who were uninterested or unable to use the app, then medical assistants would call them daily simply to have a conversation about the symptoms they might be experiencing, as well as their temperature and pulse ox values. If patients had no worsening of their symptoms for 2 weeks after diagnosis and enrollment of the program, then they were discharged from this monitoring program and no longer followed. We found that over time, both poor patients and patients of color tended to prefer the phone option over the app option. And you can see that broken down here, both by racial group as well as by area deprivation index, which is simply a measure of the relative poverty in which a patient lives. And the higher numbers indicate higher rates of poverty. You can see the blue bars indicate phone use of our program, where they would receive a daily phone call, whereas the yellow bars are patients that would use the app instead. As we started to dig into patients who wanted the phone part of the application, we found that their preference was driven at times about an inability to use an app. They didn't have a smartphone, or their data plan couldn't support the use of the data. But in other cases, it was simply driven by a personal preference for patients to talk to a human rather than the more impersonal experience of just interacting with an app on the phone. And the lesson for us out of this was that patients have different needs and different preferences. So if we want to be effective in our remote patient monitoring programs, we need to have multiple avenues by which our patients can engage with it for both data collection and communication. Otherwise, we run the risk of not meeting our patients' needs and thus minimizing the reach and effectiveness of these programs. We found that during the program thus far, there were very few escalations of calls to nursing staff, indicating that most of the patients were tolerating the COVID infection well and on the path to recovery. However, there was a higher likelihood of ED visits and hospitalizations among monitored COVID patients compared to controls. The graph shows medical assistant calls in green and nursing calls in red. And the medical assistant calls tracked with the daily outreach to patients, so were relatively high in volume. But only about 5% of those calls were escalated to a nurse for further triage and a potential escalation of care. And we actually found that overall, only about 2 to 3% of patients required that escalation of care. However, we found that patients in this monitoring program did have a 72% higher odds of an ED visit and a 17% higher odds of a hospitalization compared to non-monitored controls. And this suggested that the monitoring program could more readily identify patients and triage them to higher levels of care. Another remote patient monitoring project focused on post-operative patients. And we found that wearable detected activity and sleep quality was a predictor for post-op complications in pancreatic cancer patients. This project's being led by Ched Hamill in the Department of Surgery. He and his colleagues placed Fitbits on their post-Whipple surgery patients. They then tracked their activity and sleep quality during the post-op period. And here you can see graphically represented the Fitbit data from 2 patients from their study cohort. The first patient on the top had good resumption of activity, while the second did not and eventually needed readmission. A machine learning algorithm was able to clearly distinguish these post-op trajectories and identify patients at high risk for readmission before they got to that point. This is being further validated, and assuming continued success, will become a standard part of the discharge process for these patients and allow us to get an earlier insight into patients who may need more intensive care. Another project that's just begun is starting to look at reducing asthma exacerbations in children. Specifically, we are testing if children wear a wearable particulate matter detector. Are we able to detect air pollution sufficiently and help these children avoid asthma exacerbations? This project is being led by Maya Jareth in Allergy and Immunology and Joe Steensma at the Brown School. And the detector, which was developed here by WashU engineers, can detect smoke, biotic sources like animal dander, and abiotic sources like particulate matter in the air, all of which could have a role in exacerbating asthma. The detector itself is quite lightweight, samples the air quality every second, and is very tough in terms of its design, which is important when you're asking children to wear a monitor. We will measure any correlation that we find between air pollution measurement and the children's asthma exacerbations, and then assuming a correlation, build predictive models so that if we're seeing evidence of rising air pollution, that we can alert both the children and their parents to think about mitigation measures. The final project I'll discuss is also looking at children, in this case, children with diabetes. This team is being led by Tammy Hershey and Mary Catherine Ray in psychiatry, Jason Hassenstab in neurology, and Anna Maria Arbelais in pediatrics. The team noted that there is significant daily glucose variation among children with diabetes, which may impact cognitive function. And this is particularly important at those times of day where children are in school or doing other cognitively intensive tasks like homework. So if this relationship between glucose variation and impaired cognitive function is confirmed, then it would suggest that tighter glucose control, especially at those times of the day where cognitive function is particularly key, is warranted. So to do this, they are using continuous glucose monitors on children, and then we'll be assessing the relationship between those levels and the children's performance on cognitive functioning tests, which you can see outlined here on the smartphone. If this correlation is found, then an interventional trial would be the next step to understand how to impact this. So, as you can see, these projects demonstrate some of the promise that remote patient monitoring has in improving the care that we can provide our patients. So you've made it. You've made it through the whirlwind tour of the activities that our lab is doing, both in predictive analytics, in digital care, and in remote patient monitoring. These and other technologies in healthcare are rapidly maturing, and it is incumbent on us to study what works and then put that into practice. And as you can see, our lab is very much focused on this. We work with a large number of investigators all across the medical campus. So if you have an interest or an idea for care delivery innovation, we'd love for you to contact us. And please do so at the website address you see listed here on the screen. I appreciate your attention today, and I'm happy to take any questions.
Thank you so much, Dr. Maddox, for that review of all of those amazing initiatives going on across the hospital campus here at WashU and Barnes. I have a question to follow up in the realm of digital care. You mentioned the rideshare app, Kaizen Health. With the data that you presented, was that primarily for discharges from the emergency room, or when this was in place here at Barnes, was that for people who were hospitalized on the floors as well? And then to follow up on that, do you see that this will ultimately replace using cab vouchers or other modes of transportation to get people both out of the hospital and to the hospital?
Yeah, the short answer to both questions is yes. So the majority of those 5,000 patients were being discharged either from the ED or the inpatient wards at Barnes Jewish Hospital. However, a significant number were also being seen in outpatient clinics connected to our accountable care organization through the BJC medical group. And then we've had very small numbers of patients use it for oncology visits with the cancer center. And then we've done some inter-hospital and home transfers for COVID patients. But the majority, as you said, are coming from BJH.
And then to qualify to use the service, is it just demonstrating that you don't have a reliable means of transportation to get access to the care that you need?
That's right. The program has basically you can hail the ride similar to how you do it for Uber. The ability to hail that is given to our social workers. So if they're identifying patients that have transportation needs, then they have the ability to hail the ride with Kaizen. And we have finished our initial work with this project and handed it off to both clinical supply and the social work department. And this is kind of how we provide rides, at least in part, to our patients, and we expect it to grow and be the way that we do this over time.
That's great. Yeah, we just had a follow-up question come through about getting more information about patient eligibility for the ride share. So it sounds like contacting the social workers that we work with would be the best way to do that.
That's right.
Great. Another question that came through is, first of all, they thank you for the excellent talk. And then they're asking, are there differences in patient outcomes for the outpatient COVID monitoring with MyChart Care Companion versus just the telephone monitoring?
That's a good question. As I said, a very small number of patients needed escalation, and I don't immediately recall a breakdown of those patients who were admitted, how many were being monitored by phone or how many by app. I would say that I would guess, and I can confirm this, that there was a higher disease burden in the group that used the phone program. So they certainly were at higher risk for not being able to tolerate COVID and probably needing a higher level of care. But I'll need to confirm that looking at the data.
Okay. And then one other question I had is that you mentioned, I believe it was for the oncology risk of decompensation and the patients being taken care of, that providers had expressed that they wanted more passive alerts than an active alert on Epic. Would that be manifested then as, kind of looking to the left bar where we find creatinine clearance and allergies? And then do you have concerns that if we do make it more passive, then that useful information won't actually be utilized to its fullest potential?
I do. I really do. I mean, I think there's always a tension that we all have when we're interacting with the EHR is let me get through my work. And whenever you have an interruptive alert, that kind of stops it, right? However, if the alert is helping you with your work, in this case, sort of orienting you to the risk a patient may have, which may change the course of your care, I think all of us would be okay with that. We just want to make sure that it contributes rather than impedes clinical efficiency. So, the nice thing about Epic, even though when you look at the screen, you think it's fixed, we can actually manipulate the environment. So frankly, one of the reasons that we want to talk to folks in the audience who are clinicians is to understand how do you interact with the interface and what's a helpful place to have that information given the way that you interact with the information. And you may even be able to configure it a little bit based on individual preference. So it could be that we display it passively, meaning that you don't have to address it to move on to other parts of your work, but we feature it in a prominent enough way at the time where it's most useful to where the risk of it being ignored is minimized. But this is an ongoing sort of hypothesis, and that's what we're trying to work on.
Yeah, I totally understand that sentiment of trying to find that sweet spot of, making sure that it's seen, but not making it a nuisance. I can think of some ideas, but it's probably everyone has their own opinion on the matter. One of the residents actually kind of followed up with that too. He asks, in the projects that involved the medical team being alerted to a change in patient status, and he asks, did any issues arise with alert fatigue or physician fatigue from all the data? So did you get any specific feedback about that?
Yeah, so the project is not quite at that point. Right now, we're still designing the prototype, and then we'll need to model it in the clinical care. But I will say from other projects that have been informing this work, you definitely can get alert fatigue. That's actually one of the downsides of the interruptive alerts. And you end up, unless you're putting a hard stop in place, you end up having a lot of people just clicking through and ignoring the alerts and not sometimes taking the necessary action. So again, that's where the sweet spot is going to be. If we can have the right information that is relevant to the time in the clinical workflow provided there, then I think we can flip the script, if you will, of it not being fatiguing, but actually assisting in helping you execute your care in the best way possible. But this is going to take a lot of investigation, and we're excited to dig into it.
Yeah, I think this is all very exciting to learn about. Those are all the questions that I see that have come through at this point. Oh, we've just gotten one more. Let's see. Are there any plans to identify scenarios at risk for medical errors?
We are. So I talked about Sunny Lou's project with burnout. So that's going to be one area that starts to look into how do we characterize order errors. And, we can get kind of sophisticated on that. It may be that we can actually see somebody putting an order in error and then correcting themselves, which I've certainly done. You order the wrong dose or the wrong formulation of a medication. But even doing that, even though you happen to catch yourself, may be a near miss opportunity of fatigue or burnout or other things. We already have some programs in place to where if there's an obvious error, if you're trying to give a medication that is clearly not indicated or has a contraindication. Our pharmacy already has some programs in place to guard against those. But it's not perfect. And I think there's been some interest from some of our pharmacy teams to get even more sophisticated, looking at prescribing patterns over time or the identity of a given clinician to understand, are the orders they're putting in sort of coherent, or are they indicating some errors? For example, I'm a cardiologist. If I happen to order a chemotherapy, that would be unusual. And I think a smart system would say, are you sure that's right? Just to make sure that I'm not accidentally making a mistake. So those are some of the areas we're thinking about exploring.
Yeah, that's wonderful. Well, thank you so much for sharing with us all of the work going on at the Healthcare Innovation Lab. I certainly am really excited about all of these projects that are ongoing. And, having done my training here, I can think about a lot of ways to continue to contribute to these initiatives as well. So thank you for sharing that. Everyone should, feel free to go to this website to contact the lab if they have any ideas or are interested in anything that they've heard as well. I will share my screen so you all can get credit for being here this morning. And Dr. Maddox, thank you again. You don't have to stay on for this end part if you have to move on with your morning as well, but thank you so much for your time.
Thanks, everybody. Appreciate the time, and please reach out.